Our next speaker is Doug Hannell, and it's a real pleasure for me to introduce Doug. Doug was my last hand attending at South Carolina and my first hand attending at Harborview, and we've been friends ever since. Thank you.
Yeah, I actually feel like an interloper because I'm the only person here in this room that didn't train here. I'm also probably the only person in this room that couldn't get into this medical school.
There's a couple of us out
there you go.
Bone and I.
There you go. So thank you. It's a small crowd. It's a small crowd. So I was tasked and asked to talk about distal radius fractures, and with a quote being that there's no more benign neglect. Well, from the time that Abram Collis described this in 1814, this has been anything but neglected and has probably accumulated in such studies as this. And this is a direct quote from one of our graduates and presented at the Hand Society this year. 440 fractures. All fractures not treated closed should be treated with this, and you can put in the volar plate of your choice. He chose to do that, and all did well. In a very good prospective study that was done. And I agree with that. I agree with that totally. But I also agree with this, is that like politics, it depends on what the problem is defined, what the instruments are at hand, and what the mission accomplished is defined as being. Now, in Abram Collis' time, this was an end result that was a good end result. This was the tool that he had. And if you consider the travails of surviving the 19th century, being defined as eventual freedom, that's a lot different than it is in the 21st century. Now, the problem is, and it's this, is that if you take and you make the implant the operation, then all of a sudden it rejects or eliminates the surgeon from becoming one of those problems and becoming the problem with that fracture. And as you see in this case, the plate was applied appropriately. It was the appropriate place that was described, and this fracture went on to this result because the fracture wasn't treated appropriately. Now, from 1814 until the present, what has happened? Well, first of all, from the beginning, it's more than just a distal radius fracture. It's a radiocarpal, intercarpal, distal radioulnar joint injury that's associated with soft tissue injuries and soft tissue sequelae. The other thing that happened is Collis was, and that was his name, Abram Collis, an Irish guy. His findings were preceded by Röntgen, or preceded Röntgen by 81 years. In the mid-50s, it is determined that not all fractures do well, and those that don't do well are those of young people with intra-articular fractures, and the work of Nurk and Jupiter, which is the most quoted piece of literature in orthopedic literature, is Nurk and Jupiter's chapter, or his paper on step-offs and gaps, which Mark, wherever he is, Mark, would immediately attest to as one of the worst written papers published in the Journal of Bone and Joint. And it's a terrible paper by our standards today. And Jesse has written a rebuttal to that effect. But what has ended up happening is it has allowed us to establish a gold standard. And the gold standard is, what's my motivation? Or how do I get there from here? Which is a Ted Hansen-ism. And so if that's the fracture on your left, and that's where I want to be on your right, what does that say? It says this. And it says that. That's all I have to do. I have to get this fracture on that left to look like this, and life is sweet. And we all agree on that relative to the standards of care. And if those parameters are met, then the fracture outcome will be dictated by the soft tissue injury, not the bone alone. So the best treatise on radiology remains that of a guy named Robert Medoff in an article that you cannot get online unless you actually buy the article for $30. By that particular journal, which is a shame because this article belongs in the JBJS. But what it does emphasize, it does what we do all the time, which is determine fracture personality. And there are ways of doing this with closed reduction and closed reduction maneuvers, such as longitudinal traction, translation of the hand relative to the forearm, and relative pronation of the hand relative to the forearm. Now, you can predict and you can use this to describe how you're going to treat this particular fracture. But as Peter Cole has demonstrated before he came into his fellowship, that CT scan supplants all of this, and that and that CT scan is probably the most helpful evaluation of distal radius fractures. And as you become increasingly familiar with what a CT scan shows you, the number of CT scans that people obtain getting distal radius fractures actually decreases, but it still remains true that no fracture can be made worse or cannot be made worse with a CT scan. The issue of treatment is now gotten to the point of going to church. Basically, it comes down to this. There's very few fractures that can be treated closed. And of those treated fractures that can be treated closed, it is predicted that it is only those fractures that begin, before reduction, begin with a neutral length, a neutral tilt, have very little comminution, have no step-offs or gaps. The correlate to that is one of Margaret McQueen and Court Brown. Anything that can be treated in a cast can be treated in a splint, and anything that can't be treated in a splint needs to get fixed. And that's where we are today, and that's probably true to some extent. There are some non-displaced fractures that could be treated in a cast by themselves if they weren't bilateral. And to that end, we may push a little bit harder in those particular cases. So I think that you can divide these fractures and fracture treatment into 4 basic methods. Those that can be treated in pin or pin variants, some sort of fracture that requires distraction, simple plating or complex plating. The most amenable fractures are bending fractures. See, the most amenable fractures to pin fixation are bending fractures, reducible large parts and variation of pin techniques that you may or may not see if you talk to the vendors outside. There is no method of pin fixation that has been proven to be better than the other. The older you are, by definition, anybody older than 50 is older you are, requires something more than just pins and may require augmentation. This is a very simple 2-pin fixation technique in that particular patient. A variation on this theme is to take pins and make them into an external construct. This is a method that is proposed by Margaret McQueen, presented in 1999 journal at the OTA. And it is just basically pins attached to each other. It's an external fixture. It is not designed to allow early motion. It is designed to allow using a pin, holding it together in order to regain volar tilt and maintain it as such. Interarticular fractures, compression, shear, fracture dislocations can be divided into those that are amenable to simple single plate versus multiple plate fixation. In this particular case, if you looked at this, a very simple construct could have been used to prevent this from happening. So, how do you choose your implants? What do you do? Well, the answer is to identify the fracture fragment and then choose to address that particular fracture fragment. There's a column theory that was proposed by Wrigley, Regazzoni, championed by Rob Medoff, and then subsequently people that refer to as fragment fixators. There's a lateral column, scaphoid fracture, radial styloid, lateral radius. There's an intermediate column that has a very important fragment called the volar medial aspect of the radius, and then there's a medial column, which is the distal radial joint and the distal radius and the triangular fibrocartilage complex, and it sits on a column, and this metaphyseal column supports those articular fragments. 95% of the fractures that we treat here in a trauma setting are lateral column fractures, and of those 90%, probably all of those, with one exception of fracture dislocation or shearing fracture dislocation, can be treated with a volar plate. Any one of the manufactured volar plates that are out there in what is now a billion-dollar, multi-billion-dollar business. The one fracture that can't be treated with a volar plate is the fracture dislocation, because of the energy that is dissipated in that, and it's the one place where dorsal fixation and dorsal approaches still applies. The one thing that we did learn, and that has been championed, and is championed by people such as Cliff Jones, is that we can approach these through an FCR approach. This was proposed by and championed by George Orbet. It's really a glorified Henry approach that we all learn in exposing distal or the diaphysis. But the dissection goes through and exposes the distal radius as described. You can put your fracture fragments together. In cohort studies that describe this, it's a volar exposure, it's less traumatic, it voids tendons, it applies to greater than 90% of fractures, and in the first cohort studies from 1995 to 2010, not a single complication was reported. Not a single complication. In 2010, There are now reports using the same technique by people as good as these surgeons that there are flexor and extensor tendon ruptures, there's malunions, non-unions, regional pain syndrome, and unstable distal radioulnar joint injuries. The intermediate column. Well, this is the lunate facet. This is a very important Malone fragment or volar medial column. And in the management of these, it requires more than one implant. Two small plates placed orthogonally on the distal radius will match the bending strength of any single implant that we have on the market, with the exception of a true fixed angle device. Not locking screws, but a true metal-on-metal, contiguous metal fixation device. And there's a number of studies that have proven to be of benefit using fragments fixation, either wire forms as described by Rob Medoff, or variations on the implants that are manufactured by other companies. The problem with this particular fracture is that its exposure is somewhat unfamiliar because you have to take the carpal tunnel content radially, leaving the ulnar neurovascular bundle medially, and allows you direct access to that volar medial fracture fragment. And in this particular case, I reconstruct this in the following fashion: by removing that implant, by ignoring the incision that was placed over the flexor carpi radialis, using an incision that is ulnar, and then resecting that, doing an interarticular osteotomy, and replacing it with a very small, single, simple implant from the medial side that was part of an orthogonal fixation. Finally, these three columns sit on top of a pedestal with diaphyseal bone, and this diaphyseal bone may be the one place where we need external fixation. Or we can take advantage of not using an external fixator by using the principles that were taught to us by the late Fred Behrens. The closer the crossbars of an external fixator are to a bone, the farther separated the pins are, the more stable the fixation. And in this particular setting, we will take fractures and we'll use a spanning plate in order to treat those temporarily. And this is the ultimate stiffest external fixator, and finds its use and assistance in metadiaphyseal interarticular fractures of the distal radius. Our indications are in multiply injured patients, the burn patient, associated pelvis fracture patients that need to bear weight on their distal radius fractures. If you have limited OR time, this is a very quick and simple method to use in these particular cases. And finally, there's the medial column, which is really the distal radioulnar joint. The thing that's really remarkable about that is if you have treated the lateral and the intermediate column, you rarely need to fix the fractures of the distal ulna, the ulnar styloid. It is the reconstruction of the sigmoid notch that provides the greatest stability for these fractures. And to that end, they're treated splinted in mobilization and immobilized in supination postoperatively. If it remains unstable in supination, then that's the one indication, and probably the only indication, for fixation of the distal ulna and distal radioulnar joint. Postoperative care now is initial immobilization and forearm supination. Aggressive therapy for digit motion. Excessive pain means reflex sympathetic dystrophy or complex regional pain syndromes. The most common cause is unrecognized compressive neuropathies, such as a median nerve that is progressing through an acute carpal tunnel syndrome. Strength follows fracture fixation. Wrist flexion extension follows strengthening. What can you expect for your patients? I think 80% range of motion, 80% grip strength, a return to sensation, but most importantly, they're going to have painful distal radioulnar joints between 6 and 8 months postoperatively. So, I think he's right. At some remote time, our patients will enjoy freedom. And the most important fact of all of this is that we have liberal indications for fixation. But most importantly, the surgeon, all of you, are the operation and continue to be the operation. And the right implant matches the fracture profile, and the fracture profile is most easily identified with column classification. Thank you.
Excellent job. Moving to the polar opposite side of the body, Keith Mayo on glenoid and scapular fractures.
Thanks, Sam. The Harborview story is extraordinary for any number of reasons. I probably have a longer, at least indirect, historical connection with Harborview than anybody in this room, in that my great-grandfather, a Danish immigrant, died in Harborview Hospital when it was a county hospital in which admission essentially was equivalent to a death certificate. And you know, that's far predates Ted's involvement, but it was a bad place. And if you look at how far this has come in a matter of about 3 or 4 generations, it's truly astounding. So this is a non-technical talk. This is an uncommon injury. In 30 years, I've probably operated on about 75 scapular fractures. This is how I started. This was a Lecoq lecture comment by Charlie Rockwood. I wish I could reproduce his voice, although I can't. Basically, he was sitting in conference, and this became a subliminal challenge to me. Fortunately, one of the many things that Ted did for me was introduce me early to concepts like this. Now, you can insert any language you want now, because medicine is truly globalized, and our ability to exchange information is going to have to accelerate. So acknowledging where things come from, where our ancestors left us, I think is critical. But we grew up with this, and virtually everything that you've heard in this room today has its basis in what was, at that time, classic European literature. And this is no exception. If you look at the literature for the scapula, it started with the French, moved to the Germans, came back to the French, and then was finalized with the Swiss, with Hardiger in '84. But here's Robert Judet, who I think Ted knew, fortunately. He died early, another one of the unfortunate things for us, who handpicked Émile Letournel as his successor at the University of Paris. Basically didn't make that because of political reasons. But here's the paper. After this, there is really nothing else. This is 1964. It describes the approach. It describes the internal fixation. The implants have changed. But basically, there's been really nothing new. And that was followed by Émile Letournel. And Émile had a fascination with irregular bones, the pelvis and the shoulder girdle. There were 2 of many, along with the calcaneus. And the only thing that really came subsequent to that was our ability to understand injury patterns on the basis of high-resolution 3D reconstructions. This is really the only place, other than maxillofacial surgery, Paul, where I think 3D reconstructions are absolutely mandatory. I could never reconstruct in my head 2-dimensional scans that come up with a useful image. So we had this ability to look at the scapula as if we could see the actual injury pattern and make decisions on that basis. The indications we were left with were these, which are anatomic neck, extraordinarily rare injury, body, deformity, that's an hour discussion, and then glenoid fossa of some displacement relating to the potential for articular arthrosis. So the approach is really, the Judet approach is the workhorse. This is the skin incision. It can be modified. But this is the heart of the approach. It's a posterior deltoid takedown and the infraspinatus teres minor interval with additional other small windows utilized as well. This was the full approach that Judet described as part of his paper, which is a suprascapular nerve pedicle. And out of the 6 cases I did with Émile, only one of those actually involved this approach. All of them were other modifications, as we've seen. What does that have to do with the extended iliofemoral? Well, this is a skin incision through which you can do 3 different surgical approaches. And the same thing is true for the Judet. People hate the extended iliofemoral. I don't think anybody in this audience probably has done one besides me. Maybe Matt, hopefully. But it's a wonderful approach. It has certain limitations. And it is reserved for the worst injury patterns. But you learn how to use those indications to work with the approach. And the same is true for the scapula. So here's the typical setup, side lying, arm prep free. The old approach was the number 2 here, which was the posterior approach to the shoulder for usually shoulder instability was entirely worthless for fractures. We tried it several times, thought we had to reinvent the wheel, and quickly abandoned it. So ultimately what we're left with is basically these windows. You can see that you can put implants. You have to restore the lateral column. You can go to the spine as necessary along the medial column. And just a couple cases. So this is a true anatomic neck fracture. This is lateral to the base of the coracoid, so the shoulder is completely unstable. You can see the width of the subacromial space. The 3D reconstruction, again, showing the same pattern. And minor, very small implants used to reconstruct the entire scapula. So small fragments have replaced, or mini fragments have replaced small fragments. And then a glenoid with a scapular combination looking at that reconstruction as well. So the only evolution has been an implant. One place we haven't had to use lock plates because we're looking at very small areas of cortical bone for fixation in which standard implants are useful. So what does that mean? What is the important part of this for the history of Harborview? Well, if I could distill why Harborview has been successful over the years, I think it's for these principles. We have had the ability, and Ted was the first one to leave in Scotland, among other places, to go outside, look what else is useful, refine what you find, and when there aren't solutions, provide your own. And then the other thing, and I didn't have a chance to participate in the morning session, but the ability for a chief to recognize talent, to not be threatened by it, to promote it, it's been absolutely key for this institution. I don't know anybody else in the history of orthopedics that has done that as well as Ted has done. And I really can't thank you enough. Ted, thanks.